Good afternoon, everyone. My name is Adolf Lichtfusz, and my PhD thesis title is Management Strategies for Patients with Valvular Heart Disease. I'm a PhD student and a medical doctor at the military hospital, and my vision is that every patient should have with valvular heart disease should have an individualized treatment strategy. And my mission is to clarify the best treatment plan for each subgroup of these patients. To achieve my mission, I have two specific goals. My first project is assessing the effectiveness of transcatheter mitral valve repair on left ventricular reverse remodeling in heart failure. It's a systematic review and meta-analysis. Heart failure affects more than 64 million people worldwide, and mitral regurgitation is the most common valvular heart disease in heart failure patients, affecting almost 65% of patients with chronic heart failure and 50% of those with acute heart failure. Transcatheter mitral valve repair is a revolutionary treatment for these patients with severe mitral regurgitation and high risk for surgical valve repair. So our aim is to evaluate to what degree the TMVR procedure slows heart failure progression by inducing reverse remodeling. Our first clinical question is the following: how transcatheter mitral valve repair influence heart failure progression? We would like to compare the baseline to the follow-up data of the TMVR procedure. Our population is heart failure patients with severe mitral regurgitation. Our primary outcomes are change in echocardiographic parameters, and our secondary outcomes are NT-proBNP levels, left atrial volume, and mitral regurgitation. We hypothesize that transcatheter mitral valve repair causes left ventricular remodeling. So, for the clinical implication, TMVR could have a significant clinical benefit in managing heart failure progression. So, based on the guidelines, for this patient population with high risk for surgical valve repair, you have two options. Either you give medical therapy or you do the TMVR procedure. So, in the second part of our study, we would like to compare the TMVR reverse remodeling effectiveness to the guideline-derived medical therapies. Our primary outcomes are echocardiographic parameters. Our secondary outcomes are peri-procedural complications, NT-proBNP levels, left atrial volume, and mitral regurgitation. We hypothesize that TMVR has a more significant reverse remodeling effectiveness compared to guideline-derived medical therapy. For the clinical implication, with using our study, we would like to help clinicians to optimize decision-making between guideline-derived medical therapy and TMVR. To answer our clinical questions, we conducted a systematic search in 3 online databases. In our search key, in the first domain, you can see the mitral regurgitation, and in the second domain, you can see the TMVR technique. Our first 2 key articles are 2 recent large RCTs which contain all of our primary data. However, the first study doesn't contain NT-proBNP levels, and the second study has a statistical inconsistency between baseline and follow-up data. The third key article has reverse remodeling in the spotlight, however, doesn't contain all of our echocardiographic data. Here you can see our progress. After the conflict meeting, we would want to continue with the full text selection. On the flowchart of selection, you can see that before the duplicate removal, we had more than 9,000 articles. After the duplicate removal, more than 6,600 articles. And after the title and abstract selection, we will have approximately 600 articles. For our second project, the title is Investigating the Predictive Value of Risk Factors for subclinical leaflet thrombosis after transcatheter aortic valve implantation. It's also a systematic review and meta-analysis. Diseases of the aortic valve account for more than 60% of all valvular heart deaths, and TAVI is a revolutionary treatment for treating severe aortic stenosis, extending from high risk to lower risk surgical patients. Subclinical leaflet thrombosis is an insidious condition which can be found in more than 25% of patients within the first year following TAVI. And it can evaluate into symptomatic thrombosis or premature bioprosthesis degeneration, causing fatal neurological complications. So our aim is to assess the best prediction factors and biomarkers which could anticipate leaflet thrombosis. Our clinical question is the following. What are the most effective predictors and biomarkers to enable early diagnosis and prevention of subclinical valve leaflet thrombosis after TAVI? Our patient population of interest is patients undergoing TAVI, and our risk factors are gender, comorbidities, procedure-related predictors, blood-based biomarkers, and imaging findings. Our outcomes are incidence of valve leaflet thrombosis. So we hypothesize that identification and utilization of effective predictors and biomarkers can lead to the early diagnosis and prevention of subclinical valve leaflet thrombosis. In the clinics, we would like to help clinicians to enhance the customization of post-procedure antiplatelet or anticoagulation therapy for improved outcomes. For summary, you could see my two projects. The first one I hope that we will submit in May, and the second one in September. Thank you for your attention, and I would like to end my presentation with the words of Albert Szent-Györgyi: research is to see what everybody else has seen and to think what nobody else has thought. Thank you.
Nice presentation. My question is, what are the complications of TMVR procedure?
So the complications could be device-related or entrance-related. The device-related complications are leaflet injury, embolization, atrial septal defect, and injury to the heart wall. And the entrance-related are hemorrhage or fistula.
Congratulations, very nice presentation. My question is regarding to your second project. How subclinical leaflet thrombosis can be diagnosed?
With CT, although with echocardiography, we can find indirect signs of subclinical valve leaflet thrombosis.
Thank you very much.
Thank you.
Just for the clarification, first of all, congratulations. And I just want to ask for the first project. So you are interested only in moderate or severe mitral regurgitation, yes, based on the search kit? Okay, yes. Thank you.
Thank you.
Well, I'm really surprised that the complication rate, this leaflet thrombosis, is 25%. Yes. This means one in four. And what are currently the measures to prevent that?
To prevent it, you can tailor the treatment. For example, you can give oral anticoagulants
But I'm sure they are on oral anticoagulants.
Not every patient, because after TAVI, based on the guidelines, the basic treatment is single antiplatelet therapy. So we can upgrade it into double antiplatelet, or if we have the indication, to oral anticoagulants.
And do you remember for the recommendation level and the level of evidence behind the anticoagulation treatment in the guideline? I mean, I know it's a below belt question, but still.
You mean that yes, 1A. 1A recommend.
1A?
Yes.
No further questions
yes.
on that
Yes.
topic.
Yes.
Okay.
Congratulations. My question is, what is reverse remodeling?
Yes, so thank you for your question. So in heart failure, the heart muscle architecture changes, and this we call remodeling. But with treatment, we can reverse this process, and this is reverse remodeling.
Thank you.
Thank you.